I'm Richard Walker, Executive Director of the Benjamin Rush Institute. We hope you enjoy today's edition of the Benjamin Rush Institute's virtual events series. This series would not be possible without the support of foundations that endorse the mission of the Benjamin Rush Institute, our student chapter members, and individuals like you. Through your support, we are able to continue informing and educating today's medical students about the benefits of patient-centered, doctor-focused methods for the practice of medicine, just like those discussed in this series. I encourage you to visit our website to learn more about the Benjamin Rush Institute and the medical students we serve. While you're there, please consider a donation to support our educational programs and events just like this one. You can donate by card, check, or by mail. Thanks for your support, and thanks for watching the Benjamin Rush Institute's virtual events series.
Welcome to Benjamin Rush Institute's virtual events series. We are excited to continue this series, which we started in response to the COVID-19 pandemic. We are going to be continuing this fantastic series due to the great response that we've had, but also because so many of our medical student chapters are in various forms of hybrid learning models or completely virtual and aren't going to be having live events anytime soon. My name is Rebecca Kiesling, and I am BRI's Director of Programs. If you are not familiar with BRI, we are a 10-year-old organization dedicated to the education of medical students on free market healthcare alternatives. It's these alternatives that are not being taught in medical schools. Instead, this education is being replaced with ideals of big government, over-regulation, and big pharma. We want to push forward the ideal that doctor-patient relationships must be kept first and foremost in healthcare. Some of the biggest proponents and vocal advocates of the doctor-patient relationship are direct primary care doctors. We have heard from fantastic DPC doctors in this series, including Dr. Rebecca Bernard and our great friend, Dr. Kim Korba, as well as others on our student-run podcast, Next Gen Med. Our students have helped to advocate for DPC protection in federal and state statutes. But with more and more of our chapter leaders and members being interested in specialties outside of family medicine, it is so important to realize that there are other doctors doing great things, practicing great medicine, doing direct pay practices. Today, we are very excited to be speaking to a podiatrist who practices in Florida about her journey to direct pay. Dr. Grace Torres-Hodges is a board-certified podiatrist and has been in her own independent solo practice since 2001. She is on the surgical staff at Baptist, Gulf Breeze, and Sacred Heart Hospitals, as well as the Andrews Institute of Orthopedics and Sports Medicine in Florida. She completed her undergraduate studies at Vanderbilt University and was pursuing graduate studies in sports medicine at the United States Sports Academy prior to medical school. Dr. Torres-Hodges received her medical degree from the New York College of Podiatric Medicine and completed her postgraduate residency training in both podiatric medicine and podiatric surgery at St. Vincent's Medical Center in Jacksonville, Florida. She has been sharing her knowledge with the next generation of physicians as faculty to medical students and residents at the Florida State University College of Medicine, Uniformed Services University of the Health Sciences, and Navy Hospital-Pensacola. She's a staunch advocate of preserving the doctor-patient relationship and the independent private practice of medicine. I met Dr. Grace on Twitter and loved how she advocated hard for everything that BRI stands for, and I'm so thrilled that she agreed to join us today. Just a few notes before we get started. We are live streaming on a number of our different social media platforms, and I am looking to see that we have a number of our students and active physicians, as well as a number of our supporters that have joined us on a number of different of our webinars. I want to make sure that you ask a lot of questions. You can ask on any of the chats throughout these. You can also, as a number of our students do, text me, and Dr. Grace will get to those questions. Also, Dr. Grace is in Florida, and she's in the middle of an electrical storm. So if something happens with her video, I do have her slides, and she will call back in, so just don't leave. I'm going to turn this over to Dr. Grace now, and we're going to get started. So thank you all so much for joining us.
Rebecca, thank you again for inviting me to speak with you today. I know our audience is quite diverse, and what I hope everybody can get out of this presentation is really more of an awareness of some of the aspects of the non-clinical side of medicine that doctors are facing today in the world of private practice. So thank you for allowing me to share my thoughts and ideas about what led me to transition my private practice to direct pay. For our seasoned physicians that are out there, the idea of third-party free practice, either as a DPC or as a direct pay specialist at this point, may not exactly work for you, but for our students, our residents, and our young physicians, I really believe that forewarned is forearmed. And without this knowledge, because it's not taught in most of our curricula, I believe it's critical, particularly as our young physicians are poised to make impactful decisions about their career. This is one of those presentations, like Rebecca had said, they're not being taught at school, and I wish I had this back in medical school. So first off, a lot of people will talk about direct pay and only think about DPC because there's just more of them. So when I say I'm a direct pay specialist, I get that question. It's like, wait, you're a specialist and don't you do surgery? And I go, yeah. Can you do that? I go, yeah, why not? So I want you to think back, though, and kind of get in the mindset of what I went through with regards to switching and transitioning. Ask yourself, what do? We're physicians. We examine, we treat, we heal. And who do you do this for? You know, Hippocrates, the Greek father of modern medicine, ascribed to the notion that physicians work on behalf of the patient, not for the good of the state. So, question. Does that translate to what is happening today? Does that translate to how you want to practice? I want you to ask yourself, why medicine? What was your motivation? Think back to what drew you in to go to medical school. Ask yourself, what is it about that you love about medicine? And what does it that is still around that inspires you to continue in medicine? And if you're like most of us, it's a combination of different things. It's the science, it's the challenge, it's the risk. It's a noble profession that will always be needed. And even to a certain extent, the financial security, but probably superseding all of this is the ability to help another person. And that's your patient. And it's that doctor-patient relationship. It's so straightforward. It's that direct connection. And in a private practice, if you want to maintain a patient-centered practice model, in my opinion, anything outside of a direct pay does not offer you that to you or your patient. Because the world that we live in right now does not have that straight line. It is not clean. It is twisted, turned, rerouted, and circuitous. And today's world of medicine involves interacting with more than just our patient. It's government insurance, regulations, federal and state agencies, pre-authorizations, compliance. You get the picture. And well, where does that leave the doctor and the patient? Separated in the corners. And those of you in medical school, those who are residents and just recently graduated, how ready are you really to step into that? And I don't mean clinically. That's the easy part. The clinical part, you've been trained well through school and through your postgraduate residencies. But the whole process has been pretty safe. We know the hierarchy, we know the prescribed path, and it's been pretty predictable. But now that same methodology that you use to garner those clinical skills, you have to use that same critical thinking as you enter the physician workforce. Those skills that you've honed to observe, your self-motivation, your independent thinking now really get tested, not only on patients, but on you. And these decisions, it's really daunting. Where are you going to do your practice? Where are you going to go? How are you going to practice? And I've had an opportunity to teach young doctors and residents over the last 2 decades. I pose this question to them: what do you plan on doing after residency? And with that, most typically follow up with, well, I want to settle down. I want, and the constant answer is, I want to practice where I can work both and also enjoy a family. That balance between work and personal. But as the years have gone on, one of the notable changes that I've noticed is that fewer and fewer residents are talking about opening up their own private practice. The idea of hanging a shingle and starting a private practice appears to be so foreign to many. And perhaps it's because we've been in the academic setting, in the hospitals, and it's what you've been exposed to for the last 7+ years. But it's a lot more, it's more and more, it's become a misconception. They don't realize that there are still doctors out there that can do that. And those of us who've been practicing, I think we owe it to our new doctors to educate them about this. There's appears to be an indoctrination among students that's very rampant because of this one-sided exposure in the curricula. And inadvertently, they undervalue their assets, their worth, and they sign it away to third-party payers. And these decisions are almost like peer pressure. And they're making them quick, but they're really important decisions, and many of them signing on to hospital and healthcare systems. But without this knowledge that we're about to talk about right now, have you really been given all your options? In 2019, Merritt Hawkins conducted a survey to graduating medical residents. And what was interesting about that, there was about 66% of the residents were approached at least 50 or more times by recruiters. To the point where when they asked, what kind of practice do you want to go into, 91% of them said that they prefer to be employed by a hospital or medical group or some kind of facility like that. And apparently that has come to fruition because just a couple of weeks ago, Medscape noted that, this here, that now part of the healthcare system consists of half of the doctors are going that route. But one of the other questions that they asked a lot about was, what are your top concerns as they move on to the new phase in their career? And one of the things that came up was physician compensation. And then they asked another question. Do you think you've had enough training in this? Do they really understand how doctors get paid? And reluctantly, they admit they don't. And from this, you can see that more than half of them don't realize how that works. And they don't have any instructions on employment issues, on contracting, on compensation and reimbursement. So my goal is to kind of help you through that. And I want to go over some concepts that I think are basic, and many of you may know these, but some of you may not. I'll be honest with you, even in my journey with this, some of this was new to me because we didn't have this when I was in school and making these decisions for my career ahead. So first off, third party. That's anything that gets between the doctor and the patient. That straight line doctor-patient relationship that we talked about. A third party is when something gets in between. Then we talk about practice models. And this is the way you as a physician will choose to be employed. And there are different models. There's several models, but I'm going to go over these 4. There's an independent solo practice. There are independent group practices. There are employed group practices where the physicians each can practice solo. And then there's the employed by a hospital group or a healthcare system. Now, physician compensation. How do doctors really get paid for their services? It can be a lot more complicated than this, and some of the arrangements can be really quite intricate, but we're going to go over 3 main ones right here. First of all, fee for service. The physician gets paid for every service that is performed. So basically, the more things you do, the more you get paid. It's like going to the store when you go grocery shopping. Generally, again, the more services you do, the more you make. So you do more, you earn more. Pretty straightforward. The next one's capitation, in which a lump sum payment is given to pay for a group of patients under your care for a given period of time. It's a little different than fee for service, but it's a little bit more predictable because you get a lump sum in your payment. And regardless of whether you work or not, you get a lump sum for payment. But there's a caveat to that. If you have a healthy group of patients that you're in charge of, that's great. They will kind of come in periodically, and you can balance the books easily with that. But if you are dealing with a sicker base of patients, diabetics, or geriatrics, they can come in multiple times, but you're still going to get paid the same. And then the last way is a salary, which is a negotiated rate based on employment. And associated to all of these things is what we call a fee schedule. And this is a list of charges for healthcare services. And there are two types of fee schedules. And this is basically like a menu. The physicians have a fee schedule. It's what the doctor gets to set. It's their own prices, okay? And then there's a third-party fee schedule, and that's the payer. And they dictate what they are willing to pay for various services. And if you sign a contract with a third-party payer, the physician cannot charge a patient more than the amount that the third-party payer sets. And that's important to remember. And how do they set these fee schedules? They use things like CPT codes, which is basically a list of numbers that corresponds to a specific procedure that a physician does. For example, a CPT code of a 99203, that's your new patient visit. Pretty straightforward. The ICD codes are the diagnosis that the physician uncovers or is treating while performing a given CPT code. So using the example of a fracture, and I'm going in during a visit, I examine the patient, I find that there's a fracture. So I find the ICD code of S92355 on the right foot. And then I will do surgery on it. And then that code has to match up with the diagnosis code has to match up with a procedure code that's going to be treating. ICD codes were initially used, though, for tracking public health conditions and to make claims processing easier for insurances. Over time, as we get through this presentation, you'll see they become much more complex and serve more functions. So let's see how all these entities react and interact with each other. So in general, like what we said, there's a doctor-patient and relationship over here, and anything that gets in between is a third party. And in this case, we're talking about insurance. These third-party payers, I want you to understand what's actually going on in here. They exhibit economic leverage over the doctor's business as they are defining how much you will get paid and the method at which you will be paid. But what's also interesting is that they're exerting economic leverage also on the patient's healthcare decisions by determining what service they will or will not pay for. And when an insurance company denies a claim, the patient is sometimes not financially able to afford that service. So this gives the third-party payer incredible leverage with both the doctor and the patient, and can sometimes, that playing on both sides puts a rift between the doctor and patient. And before we get on with anything else, I do want to make sure that you pay attention to terms. And one of the reasons why I like to go through these individual concepts is to define terms. One of the biggest ones that you can see that is blurred these days in most anything that we read about this is that healthcare and health insurance are not the same thing. They keep interchanging these terms, and it's an important distinction to make. There's a difference between healthcare, which is providing the care, which is what doctors do, and health insurance, which is paying for the care. And that's important to make sure you get. Because insurance, which we're all familiar with insurance, it's a contract arrangement which transfers financial risk resulting from catastrophic loss over to a third party. And think with car insurance, we get that better. It pays for catastrophic things, not the routine stuff. And we get that. We don't pay for gas. We don't pay for oil changes or AC repairs. But when you're in a wreck, there's a deductible, okay, to meet. And then typically insurance is there to use and file the rest of it so we avoid financial catastrophe. With health insurance, that's not the case right now. And through the years, its perception and the practice has actually morphed. So much so that patients now are surprised when something's not covered. They question if it's a correct treatment. They question if it's medically necessary. And again, that puts a rift between the doctor and the patient when things are denied and not covered. And so what actually changed? Doctors agreed to provide the care, but insurance changed the rules. So let's look at Medicare. It's the biggest player out there. It's the most followed one by the private insurances because they usually take the lead of Medicare. And have you ever read the original statute? Section 1801. And I'll read it here. Nothing in this title shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine, or the manner in which medical services are provided, or over the selection, tenure, or compensation of any officer or employee of any institution, agency, or person providing health services, or to exercise any supervision or control over the administration or operation of any such institution, agency, or person. That's Section 1801. Under, it says, prohibition against any federal interference. They reneged. The premise when it was first written and passed was never to interfere with the practice of medicine. Whether it was intentional or not, third-party influences have had a huge impact in the clinical practice of medicine. So for our private practices, physician-owned ones, they're all small businesses, and they have to run their practices like a small business in order to stay financially sound. As a physician owner, I have to make sure we control the expenses and respond to market demands, whether it's office space, payroll, equipment. You see our list over here. But we also have some extras in order to practice our profession: malpractice insurance, licensing and board fees, professional association dues, CMEs. However, when you sign a contract with third-party payers, you are giving away some of your most important power as a business owner: the ability to change your prices and your operating procedures in a way that will respond to market pressures and your own unique business circumstances. In short, when you let somebody else tell you how much you can charge and what administrative policies you must follow, in effect, they run your business, not you. So what happened? Why have third-party payers exerted more increasing amounts of influence in the clinical practice of medicine? As you can see from this graph, this is noting the healthcare expenses in the United States. They have exploded over the last 50 years. And there's several reasons for this, but for purposes of our discussion, when a third-party payer is paying for the service, the person receiving the service has no economic incentive to keep up with the costs because they're not the ones paying for it. It doesn't really lead to a frugal consumer. You hear it all the time. My insurance covered it? Oh, good, great. And when you do accept insurance as a physician, there's even more good news. You have to comply with bullet points within your note in order to qualify for an appropriate code, your CPT code. You have to agree to the terms of a fee schedule. And in this case, a visit is actually charged by the doctor at $90, but the insurance company has a contractual agreement with the fee schedule is only allowing $65.70. You automatically just give away $24.30. And what's even more insulting, so the patient pays $65 and the doctor only gets a 70-cent check. And then in the midst of all this, you still have to ask for permission because sometimes they won't approve it. So you have to ask for pre-authorization. You wait days and weeks to get reimbursed. You can actually cure and treat something and still not get paid for it. And there's a stipulation. Doctors' offices have to file within a specified window. But they can't wait to file. And you can be audited. And usually these audits are by non-physicians, just someone doing paperwork in the back. And then worse is some insurances can take back the money if they feel that from the audit, you didn't do it right, according to some code. And that can be 3 years afterwards, you can get a request for money to be returned. And when they do send it, it makes you wonder. This was a 6-cent check back to my office when I was still doing insurance, and it was a 40-cent stamp. How fiscally responsible does it show? And worst of all, your patient has no idea that this is going on in the background because it's not their problem, it's your problem. The way I want you to think about it, like you're going to a restaurant and for some reason, all you want to do is you go over there and you want your steak dinner. You don't care what's going on in the back as far as if so-and-so didn't show up to work or that they've been backed up. You just want your steak dinner. So think about that when you're signing on to insurance companies, because as long as there's a third party involved, they are in the exam room with the doctor and the patient. And at that point, the doctors are indentured. The sad part is that most of the public is unaware of this. Most doctors are unaware of this. And from the public perspective, the public's also at the mercy of the insurance carrier if they're expecting for things to be covered. So a key thing here is whoever sets policy and administrative practices actually runs the business. Now, I would be remiss if I didn't point out that these administrative structures and economic incentives are not just present in small, single practice physician offices. They are also prevalent in impacting every aspect of healthcare delivery throughout the entire system. In fact, in larger organizations and hospital-based systems, a good argument can be made that the situation may be even worse. Look at this graph. So this shows us the annual billing charges versus actual payments for U.S. hospitals. And what is being billed is in the blue, and what is actually being collected is in the green. And so when you consider the additional staff and management layers in a large organization like a hospital, you can easily see how the relationship with your patients can become impacted. The doctor is often turned into a cog in a much bigger machine, and that job security is not always what you think it is. And if you're still not convinced by this, consider this graph. And I want to thank John Chamberlain over at Citizen Health for allowing me to use this. The green line is the growth of physicians over the last 40 years. And the shaded red area is the growth in healthcare administrative staff. Somebody has to fill out that paperwork that I mentioned throughout the presentation, and this graph is as good an indicator as any of what that does to the healthcare environment. To work with insurance companies, it takes coordination, it takes staff, and it takes someone to oversee it. But what happened to the doctor who's actually doing the work and the patient who's receiving the care? With all of this growth, has it actually improved the clinical situation. So when you get involved with third-party payers, you don't only take on the responsibilities of your own organizational challenges and market forces, you also are giving considerable control of your business to outside entities that have their own economic and political challenges. And in such an environment, they will almost certainly put their interests first and not yours. And bear in mind, there are very, very many ways of a carrot and stick approach that we've seen that they've been using to keep and gain compliance and control over the healthcare system. To name a few, electronic health records, electronic prescribing, PQRS, MACRA, MIPS. What's next? So let me put a face on this, and particularly for those of you who are looking at what's going on after residency. This was my story. So I started out in a 2-doctor practice right after residency. I was excited. I was employed and my contract was on track for an associate to partnership. I was ambitious. And as my contract stated, I would be given a salary plus a bonus on a percentage of revenue of what I would bring to the practice. I worked my butt off that first year and then couldn't understand when we were looking at numbers at the end of that time, it wasn't showing what I thought was happening as I was working. I found out that I was only assigned insurances that were reimbursed by capitation. That was my lesson number 1. I was frustrated, but I'm still empowered. So I left that practice and opened my own and did not contract with capitated plans. Being my own boss was great. And since the beginning in 2001, we've actually had steady growth. However, during my time when I was with third-party payers, new regulations kept getting initiated over and over again. So they would get everyone on board by enticing them with incentives. And then if you weren't compliant by a certain date, you were penalized, which usually meant you had a reduction in your reimbursement rate. And this was like an endless array of acronyms. Like I mentioned before, EHR, e-prescribe, PQRS, meaningful use, MACRA, and MIPS. And then on top of that, they switched from ICD-9 to ICD-10 during that time, and they increased the numbers of diagnosis codes from like 14,000 to almost 69,000. Looking for a code for like a fifth toe fracture from one code to 8 different codes based on how it's healing and how it was actually how you injured it. And for what? Not for the doctor, because all I know is that I've got to treat this fracture, but it was for a third party to keep track of what I was treating and how it was healing. Now, keep in mind, implementing all these regulations like e-prescribing and EHR required new equipment, and these were huge overhauls to our computer systems that were also a huge financial investment, not to mention the learning curve of incorporating these into practice, not just for me, but for my staff. As a small business owner, each regulation came with more administrative paperwork above and beyond what we were already doing, which included the tasks of filing, of billing, of authorizations, of referrals, of follow-up on denials, of filing secondary insurances, and then audits. And then one day, while I was at home finishing patient charts and audits, my husband asked me, "What are you doing?" And then he asked, "Does what you spend your time on most do anything for the mission of your practice?" Which for me was to provide the best podiatric care to my patients. And I thought about it. No, it did nothing for me or for them clinically. It was just extraneous and administrative. My aha moment came when I called the plumber to fix our bathroom at home. I went on Facebook, asked for recommendations from friends. I wasn't being told by someone that I have to see this person because of the way an insurance company would pay for it. There was no network to deal with. I called the plumber directly. No referral process needed. He evaluated the situation. He gave me my choice of options. He gave me a price straight up. And he gave me the choice to take care of it myself or to have him do it. So he repaired it. And then since I already knew the price, payment was quick. There was no delay. He got his money and I was satisfied. Both parties were satisfied. At that point, I realized insurance was clogging my practice. So I broke free and I was tired of being bullied. I was beginning to dislike what I was doing. I was about to burn out. The patient and physician relationship is so sacred to me, and any decision for treatment should be the result of mutual discussion and acknowledgement of those two people, the patient and their doctor. My decisions regarding quality care issues are always going to be driven by what I believe is best for my patient and their individual needs. I was tired of being told that even though the patient came in with 2 problems, I should only treat one and have them come back because it wouldn't be covered. I was frustrated with my surgeries, and when I did more than one procedure on a patient, that the insurance company would pay for the first one and then only pay a portion of any of the subsequent procedures that were also associated with it. I was tired of being told by someone who wasn't even a doctor that an MRI that would not be covered for treatment of what was a non-healing ulcer. I wanted this MRI done for my patient. He saw me outpatient, and I was suspecting an infection. I wanted to properly plan surgical debridement. So outpatient, I was going to send him for an MRI. The insurance denied it and would not authorize it. And so what did I do? I had to take care of my patient. I sent him to the ER. And he racked up a higher bill because there they would see him because he was in the hospital with an open wound. And ironically, in that case, the patient that I sent and who this happened to, he's probably one of my biggest advocates of why of telling others about the importance of transitioning to third-party free practices. Unfortunately, the reality is that today in healthcare, with third-party payers, doctors are being told what their options are, which is basically, you play by our rules or you face penalties. It's never been more challenging to be a physician right now. And every year, medical economics always puts out the top challenges facing physicians. Number 1 on there is administrative burdens. What's interesting, in 2018, and this was the year after I had actually opted out of Medicare, which was my biggest one. I even tweeted about this. They rephrased that question. Instead of asking what are the challenges, they asked, what's ruining it? What's ruining medicine for physicians? And what came about from that was paperwork and administrative burdens, difficulty using EHRs, government regulations, prior authorizations, and so forth. And you can see over there, I was so happy when I saw this come out, but I tweeted that if you went direct pay and opted out, most of these things that were ruining things for physician would be significantly reduced or would go away completely. And one of the things I want you to remember is that first, you have to take care of yourself if you're going to take care of others. So for my practice, what I did was I was changing a standard. So for those of you who are thinking about what to do, and this is probably more important for those who have already been in practice, preparation is key. You want to educate yourself. I went to conferences. I networked with other doctors who were doing this, whether they were DPC or specialists. I talked to my patients and then explained to them this whole process. I made them realize that we were both being played. I'm not the bad guy. I told them that what was covered and what was not, and let them figure out the insurance logic. I spoke out in person and online on social media and was able to find more and more people to network with. I evaluated my process, my practice. I made a set of goals for office growth and things that I wanted, which was actually just personal things like family time and a good use of my time, seeing patients, not doing administrative work. I looked at our office expenses and, like a business owner, really buckled down on what we were spending and paying attention to what was actually coming in and looking at the reimbursement rates or returns from all of the insurances that I had. And each one I would drop off more and more based on which ones weren't paying me the actual amount of what I wanted on my fee schedule. And then I prepared things. I prepared my staff, which is probably the most important thing, because they are the ones that are going to help you convey your message. And then we streamlined the processes, had scripts ready, anticipated these questions. And then we have remained and stayed frugal and anticipating that we were going to have a loss. But it paid off in the end because we didn't have that big of a loss. It's always good to be prepared. For those of you who are just now coming out and actually practicing for the first time, I think it's actually even easier because you're still having to gain new patients, build a reputation, grow a practice. List your goals down, know your worth, and commit to your mission. Accept that patients do have choices to use their insurance or not. And probably the biggest thing, compete on your value of what you are able to give, not just on a price. And reach out. There are several ways to contact specialists who are thriving in direct pay. Organizations that have lists of them include DPC Frontier, the Free Market Medicine Group, the Wedge. Look at facilities like surgery centers, like Surgery Center of Oklahoma, have been successful in thriving with direct pay surgeons. And then talk to specialists. And these are some of the ones, some of the doctors I talk to and still talk to shoot ideas back and forth. Dr. Held, Dr. Davis, and you can see Dr. McKnight, who happens to be in my hometown also, Dr. Giannoli, Dr. Brown, and Dr. Giulipili. Reach out to them. Everybody's willing to, because once you find out what's going on, you want to spread this to others. And just keep in mind, you're not changing the way that you practice medicine, you're changing the way you interact with the system. And that's really important. You're not giving up anything that you wanted with this doctor-patient relationship. And it's important that your patients realize you're not abandoning them. You're abandoning the insurance company because you want to get rid of the things that are getting in the way of taking care of them. And as a small business owner, you run your business better. It's more patient-centered. You get a better return for your time, effort, price, transparency. It's honest. And you put patients in control of decision-making. And you don't get any more bullying by insurance companies. I don't have to worry about coding now and bullet points to meet administrative criteria. And my SOAP note, the note that we are all taught how to do, subjective, objective assessment plan, it becomes an actual information center rather than a template of 15 pages. And then the most important thing, personal satisfaction. As an entrepreneur, you're the boss. You make the call. There's no insult to your physician worth. Medicine is fun again. And there's more time for your patients, and there's more time for you and your family. So one of the things I want you to keep in mind, what you're looking for in your patients and what you want out of your practice, remember why and what motivated you to become a doctor. Don't forget that you're the value and the asset. It's your knowledge and skill. So don't sell yourself short. And the goal of a business is not to do business with just everybody. The goal is to do business with the people who believe in what you do. And that's how trust emerges. That's how the doctor-patient relationship emerges. And there's a concept that Hippocrates said that was primum non nocere, which means first do no harm. As much as we first do no harm to our patients, it is important that we practice this clinically and financially for our patients. And most importantly, we should practice that with ourselves. It should start with ourselves, not to do harm. So I hope that has given you some things to think about.
I want to Thank you. So that was fantastic. First of all, I want to say, I'm not sure if you knew you had Dr. Kathleen Brown on your list. Her husband sits on our board. And they're great friends of BRI. I didn't put that into your list. So if Dr. Brown is watching, they're both, the Browns are such great supporters of BRI, so we're thankful for them.
I met them about 7 years ago at one of my first conferences. So
I got some new people to talk to as well. So thank you for that.
You're welcome.
My first introduction to DPC and direct pay was my first week, or first 2 weeks at BRI over 2 years ago now. I listened to a DPC doctor out of North Carolina. I always tell this story because I think it's very telling. I loved what you just spoke about your own practice, and I'm going to see what I want to be conscious of your time because I know you have patients. So many medical students don't understand. There was a DPC doctor who opened up her own practice out of North Carolina. Her name is Dr. Amy Walsh. She had practiced medicine for 20 years and got very disenfranchised. Just didn't want to practice medicine anymore because it's not the type of medicine that she wanted to practice. And she walked away. And she came across a conference visiting Florida with her family, and was walking around a conference hotel and fell across this medical conference. She's like, my people, and fortuitously learned about DPC. Had never heard of it before. 20 years into the practice of medicine. 18 months later, she opened up her own DPC practice. And I think what's so telling about what you just said is that if you plan and if you understand that you can have a good practice of medicine and you can stay solvent in your practice. Right. And she said that in her telling of what she did with DPC. Mm-hmm. And I think that planning, and it's what we tell medical students to start out. And, we don't do enough business planning in medical school. And that's something with Jack Brown and now Dr. Brown, they're looking at doing is, and I love it, is looking at the business practice of medicine.
Right, right.
And I love that you put that into your presentation because I think it's so important.
It's just not taught out there. And when I converted, because I'm now in my fourth year I'm approaching my fourth year of no insurance. I actually had a question came in: how long did it take for your practice to thrive again into direct pay? There's your answer. But yeah, no, I came across a conference, the same thing, just like what you were talking about with that North Carolina DPC doctor, just randomly, just in an email, because, you get frustrated and you love what you do. I love what I do. I mean, I help keep people independent and pain-free, but now when you find all the intricacies of what's actually going on, you're being used. That's what it came down to, and you don't like to be bullied, and So I hope people realize that, and I think the biggest thing, you get so jaded when you get out of residency because you've been just so bogged down with work and work and work. Then you get open to this physician arena, and then you're like lost again. And these are the brightest people that get into medical school. We know how to get out of situations, but for some reason we are not able to get out of this one. And so I'm hoping that more, and I think that's the common theme among anyone that's direct pay. We have to get this message out there because we have to save our profession.
Well, that's what we're thankful. BRI is thankful for people like you, because our goal is to start that education as early as possible. Because that burnout rate is so high as people start getting disenfranchised. Again, I use that word as they start getting burnt out, as they don't understand that they can practice the medicine that they went into medical school to practice. So the more that we start the education early, get that information out. So the other part of that question that you just saw was your marketing budget. Do you set aside money to market? I learned about what you do through Twitter.
No, I don't. I never did even before advertising. I mean, I started when it was still phone books, and I thought phone books were the biggest waste in money. When social media exploded, social media is probably one of the easiest ways to do it. And the best way, and your best referrals are always going to be patient to patient. Anyway, it's always going to be getting referred by a family member. So no, I don't set aside a specific marketing budget. In my town, I'm in a nice suburban area. I sponsor clubs for kids a lot of times. You sponsor a baseball team, little league team, and all that. So your name gets out there. But then you talk to the parents. I give early on. I did a lot of talks at retirement centers, at nurseries, to talk to the parents about their kids' feet. You find your niche, but I always believe in word of mouth. But use social media. My gosh, you've got Instagram, you've got Facebook. Do I pay for that? No, I don't. But then again, I'm also now approaching my 20th year in practice. I've had a reputation here. But the kids nowadays, they know how to work social media. They can boost their ratings and numbers up quickly. So, that's how I would answer that. I wanted to add a little caveat, if you don't mind. I'm the product of two physicians myself, and both my parents, a surgeon, my father, and my mom, a cardiologist, practiced for 50 years. They left practice because of all the changes. Part of it coincided with age, but as they look at it back now, it's amazing. They are surprised how just bogged down things are. And the fun thing is, when I dropped insurance, I had more free time because my time was more efficient. I actually was able to. My parents both volunteer at a local medical charity here in town. I had time to join them there, because I could set my budgets properly during the week. I know what's coming in. I know when you're trying to make ends meet because reimbursement rates aren't matching what it actually costs to run your practice, you don't have that free time. So, I just wanted to add that because, a lot of people say, oh, you're just in it for the money. No, you're not in it for the money. There's ways to give back.
When you were shifting to DPC, or for people that are considering opening up DPC, it's my vernacular.
Yeah, understand.
A direct pay practice. Mm-hmm. So whether it was you shifting or somebody that's considering opening up a practice against more well-established practices, how would you talk about that? What would be, how can you compete against that?
Well, again, you're not competing against the price. That's why I put that quote in there. Don't compete against price. Compete against value. That's the thing. I had a young podiatrist actually who's now practicing in Louisiana. He bought a practice, and I hope he doesn't mind me saying this, but he bought a practice from an existing podiatrist who had been on insurance claims and everything like that. And as he's been going over and now taking over the practice, and it's assimilating to him, he's talking to the patients and giving them a choice. Do you want to switch or not? Do you want to stick with me? You want to try me out? Prove yourself. That's the thing. Whether you are established for a long time or just starting out, you still have to make that connection with the patient, and so is it a little bit harder? It could be harder. One of the things you can do, like fairs, I told him to go to, again, to charity workplaces, and offer your services there, because then people who are working, who aren't the charity recipients, they hear about what you do, and then they'll send people that they see your work.
Yep.
So let your work speak for it, and don't compete on price, compete on value.
This is a great question. Have you encountered any problems with ordering diagnostic studies?
No, not at all. That's not anything. Most of us have had the fact that I dropped insurances, and that usually becomes a question with dropping and opting out of Medicare, because they're so stringent on that. No, there's no change. Like for me, the diabetic shoe program is something that we do a lot with. I don't do it in my office, but I refer that out. I can still do all the referrals. I can order tests. I can order labs. That doesn't change anything because I'm not the one being paid. It's the facility. It's the lab. So you can still do all that.
So I remember talking again to Dr. Walsh about this same thing. How did you determine your fee schedule, both as in your office, but also as a surgeon? Like, how did that happen?
So mine was because I was in practice already. I looked at my fee schedules from the various insurance plans that I was on before, and then kind of averaged out what it was. Then I also looked at how complicated are these procedures. It's amazing, what they call the charge masters who decide these numbers. They don't know how intricate some procedures are and how much follow-up is on certain other ones. So I had my old fee schedules to work with, and I looked at that. But one of the things that we have now, there are so many online sites that have cash prices already listed. They didn't have that 5 years ago. They didn't have as many of those out there.
Right.
You can go online and see what your range to work with is, and then throw it out there and see who bites. See, basically you throw out you figure out what price will work for you. In your own practice, you have to figure out also, I look at things down to how much does the paper that we use in the copying machine cost per sheet. I'm geeky like that. But if you know how much your room makes with each patient per minute, and then you also put in the procedures that you're doing, that's how you that's how you figure out your fee schedule. But nowadays, I think those that are coming out, if you want to do fee schedules, there's so many cash listings online now. There is a little bit more price transparency. I don't think David Balat would think that, but I know he's always pushing it, which I'm all for. There's more price transparency online, and prices are listed, so you can see what's going on.
I was going to say, I could throw you a few of our speakers that might say, we need a little bit more of that.
No, I know. I agree with him, though.
Yeah, absolutely. It's something that, we belong to the Free to Care Coalition and pushing hard for price transparency across the board, which for people in independent practice like yourself that don't take insurance, it's only going to be more helpful. So if anybody has any additional questions, we're right at an hour now. Dr. Grace has patients that are waiting for her. As I met you on Twitter, she's Dr. Grace DPM on Twitter. She is an enormous advocate for the doctor-patient relationship. We're on Twitter at BenRush INST, and that's how I came across everything that she's doing. If you want to be in contact with Dr. Grace outside of Twitter, my contact information will be on the slides after that. You can just get in touch with me at rebecca@benjaminrushinstitute.org, and I will get you in contact with her. I am so thankful for what you are doing to promote the doctor-patient relationship. I'm thankful that you've decided outside of, what we all necessarily hear about in the news as the direct primary care, which is fantastic, don't get me wrong, but that you're doing so much to promote it outside of that. Keep doing it, please, and keep speaking to it, because we need more advocates like yourself. Thank you for your time. Thank you for this great presentation, because there was so much really good information in there. We are going to continue our virtual event series. So stay tuned. If you'd like to sign up for our newsletter, which hosts all of this great information, please go to our website at benjaminrushinstitute.org. Sign up for our newsletter. You can also follow us on Facebook or Twitter. And we thank you so much.
I hope you enjoyed today's edition of the Benjamin Rush Institute's Virtual Events Series. To learn more about our educational programs and events just like the Virtual Events Series, I encourage you to visit our website. While you're there, you can subscribe to the Benjamin Rush Institute's YouTube channel and link not only to all episodes in this series, but also to all of our past meetings, events, and conferences. And please consider supporting our work on behalf of the medical students we serve by donating to our efforts. Your support is vital if we are to continue to provide important educational programs and events just like this one. We appreciate your support, and please watch for your invitation to the next edition of the Benjamin Rush Institute's Virtual Events Series.